Thank you for having me speak today. I really appreciate doing these venues. One of my biggest interests is actually sports nutrition. I really enjoy talking about it. So thanks, Dr. Peifel, and thanks, Dr. Elder, for coming all this way to give us a great talk on concussion. So I do have a disclaimer. I do own some stock in MOSH, so I needed to disclose that to you guys today. But I'm going to be talking about a few hot topics in sports nutrition. And these hot topics that I'm going to talk about are limited to 5 categories. And I think these 5 categories, almost everyone in the room could really identify with. How many people either do organized sporting events like marathons, short runs, triathlons, or any sort of maybe boating type activities, kayaking? Can I see a show of hands? How many people do those sort of things here? So I always love these sort of communities because most people in the room are athletes of some sort. Either they be, non-professional or professional. So these topics really are something I'm interested in about, and most people I think in this room would be too. But I can take questions on other things at the end of the session at any time. So the few topics here are hydration, and I think that really centers itself around salt. And then I'm going to talk a little bit about carbohydrates, proteins, and then get into a little bit of the supplementation, and that's going to be creatine because that one is the highest money seller even to date in regards to supplementation. And supplementation is interesting because it's really not followed by the FDA at all. It's deemed a supplement, and that came through a bill called the DSHEA Act that allowed supplements not to be regulated by FDA, and so that meant that companies could send these products out and not have the same regulations as far as what the quantity of medications are in the particular supplement and what actually is in it. Is it really that only substance, or are there other substances inside those pills? And so we'll talk a little bit more about that when I get to that section. And then steroids, and that's certainly a big topic of discussion even today. So, hydration. How many people in this room have seen people who are dehydrated? So almost everyone in the room, 90%. And one of the things I always find confusing, even with Dr. Elder's talk, because he touched upon it, was how do you tell an athlete that's dehydrated versus a concussed athlete without knowing the mechanism of injury? So I think, clearly knowing that mechanism of injury is going to help you. But boy, the symptoms are pretty close together. So salt loss is really through sweating, right? Because you lose salt and you lose liquid. And you really see that on the clothes. Some people are what we call heavy salt excretors, and those people have actual stains on their dark clothing of white kind of pattern, looking like maybe a cloudy kind of pattern. And some people who don't sweat much at all, but their clothes are wet, but they don't have like a white stain on them. So there's a different maybe phenotype of person that might be a heavy sweater or not a heavy sweater in concentrations of salt and water content. And so if you work out and you work out regularly and you're an elite athlete, you're going to acclimate to losing less salt. You're also going to be able to be a better sweater. So you might sweat earlier, you might be able to cool yourself down, and you may have a less salt content to it. So that's good. And so with fitness, we can see that. And the elderly and people with medical conditions are often compromised because either the pills they have to take for those conditions or the fact that they're a little bit older may alter the way that they actually sweat and the content of their sweat. So I'm going back to biology, and all I really want with this slide, because it's certainly very busy, is to show you that the cell has a membrane, and that membrane has, chemicals that go across it, and some of those are big chemicals, some of those are small, and what I'm really important for us is really kind of salt. And so sodium is what I'm really referring to, and I put a big red circle around it. And so same thing even for, cells of either muscles or nerves. It's still that same sort of mechanism, that transporting of certain ions across the membrane. It helps that muscle or nerve tissue or cell function. And so if we're not properly hydrating ourselves with those sort of sodiums and other electrolytes, we're going to get into trouble. So hydration, what are the signs and symptoms? boy, if you're not really acclimated, if you're not fit, you're going to be a heavy sweater. And so heavy sweater, you're going to have more sodium loss. Sodium loss can lead to dehydration and poor performance. It can lead to cramps, fatigue, headache, nausea, and the worst one that everyone would fear in this room is, heat exhaustion then leading to heat stroke, and that can be associated with death. So there's a person, does everyone know who Korey Stringer is? So, Minnesota Viking, ended up dying a few years ago. He had heat stroke, he had multi-system failure. And so there was a Korey Stringer Institute that was developed, and it comes out of the University of Connecticut. And there's a person by the name of Doug Casa who runs this institute with the Stringer family. And they really put out a lot of good information about how to prevent heat stroke, because that's really what this talk is all about in the end, because you really want to prevent someone from having complications like that. And so if you ever have a chance, you could Google that. And we did it here at MOSH, and all the trainers at MOSH are certainly aware through Mike and Mark about these sort of institutes. So it allows us to have a place where we can go get our questions answered if the physicians aren't available, or you guys are, your colleagues aren't available, or how you can get things kind of available to you to prevent heat stroke. So why is it important? Well, I think everyone in the room, since the show of hands was pretty large in regards to sporting events that everyone participates in, is, well, not only does it prevent illness and death, but it improves your performance. So if you're dehydrated, you're not going to perform as well as you'd like to. You're not going to make the time. You're not going to, make as many baskets, get as many touchdowns, and so on. And so the issue is, well, everyone plays in these events to either get a good time or to win games. So that's why I think the most important is. And so what's the pathophysiology of how we lose or how we cool our bodies down? And so it's really through evaporation. And so evaporation is really a conversion of a liquid to a gas, and that can happen on our skin or in our lungs. And this heat loss is best available when the external temperature exceeds that of the body. So that way, does that make sense, everybody? You got to think about that one for a little bit. That means if you got wet on your skin and it's hotter out, it's going to evaporate faster, it's going to cool you off faster. And it also decreases if the humidity is high. So if it's kind of moist outside, you're not going to evaporate so much liquid off your skin, you're not going to cool off. So the predisposing factors to it are multitudes, but in general, it's older persons, young children, because they usually have, kind of a large skin to body ratio, and patients with, kind of poor conditioning or chronic disease. So that could be at any age. And so if you really have these troubled situations, you're just going to lose more water and lose more sodium, and there be it at an imbalance. And so what are the major illnesses that you see out of these things? Well, there's a list of them. And, everyone knows about cramps. How many people in this room have treated athletes with cramps, particularly football? Everyone almost in this room, I'd imagine. And so we think it's heavily related to the sodium intake and their proper hydration status. And so there's other little things that we see, like tetany or syncope or edema or prickly heat and heat exhaustion. But the most important one is heat stroke. And I don't think that football player is going to get any problem. And so because it's really, really, really common, heat exhaustion is really kind of the most common. You don't really see many heat strokes. You see those other things, but you kind of see people on that verge of kind of a heat exhausted state. And that really kind of goes into all these different things. And if you see the similarity between those signs and symptoms and concussion, it becomes a little bit confusing if you don't know that mechanism of injury. And so it really is interesting, because when you have that exhausted person, you say, wow, you're certainly, you look okay, you're sweating, but they still have these other sort of, cognitive impairments or other problems. And there really is no, if you catch it early enough and things look okay, things are going to clear, everyone's going to be fine. So there's going to be no end organ damage, and there's not going to be any sort of troubles that are going to be long-term sequela problems. And so the core temperature is probably the key thing because you don't know. Are you exhausted? Are you maybe beyond that? I can't tell. But if you did a core temperature, which means by definition you would have to do a temperature like a rectal temperature, is probably the gold standard. There are other ways to monitor, but that's certainly one of them, and that's the gold standard. It would be less than 39 degrees Celsius. And so that would tell us, okay, you're not really getting into the danger zone of the heat stroke. You're getting there, but right now we can sort of manage you, things are going to be fine. And if you think of, what would you do? I think most of us in this room would say, well, we better rapidly cool you. So let's get you in the shade. Let's take you out of the sunlight. If we have, some way of cooling you off a little bit faster, like an immersion pool with cold water in it or ice, we can do that. But even putting ice packs on or fanning would help, and really rehydrating. And if it's to the point where they're having troubles with some vomiting, because often they do, then you may have to get an IV in place to put it in. So I remember when I was a resident long ago, because now I'm getting a lot older, the marathon was in town, and they wanted me to cover it, and I asked, well, how many of these people that are going to be running the Lakeside Marathon are return marathoners or have run marathoners before? I don't know. Well, who was going to be there? Well, you are. Is there anybody else that's going to be there? Well, there'll be a tent, and there'll be some volunteers. Are they athletic trainer or are they kind of medical personnel? No, you are. And I said, well, how about, is there going to be any sort of paramedics there or anybody that, how are we going to have like IV access or anything? No. I don't know. I don't think I want to do this anymore. It sounded like a good idea, but I don't think I have the correct personnel there to kind of help me. And so I ended up not doing it, and one of my colleagues ended up doing it, and he said that was the most miserable experience he ever had in his whole life, and that they eventually just kept a rescue squad there because he had called them so many times that they were just running back and forth. So Bell Ambulance they called him up, said, hey, do you mind if we just keep a couple people there because you've already called us 10 times? And so he ended up sending about 45 people to the emergency room. And so I think it's really important when you're at an event like that to have different ways of access. And oral is a great way, but IV is certainly more effective if you just can't get it down. And so I don't know how many people had to look at this kind of hyponatremic, hypernatremic. Those of us that ever did pediatrics or, kind of ICU medicine, we had to learn these stupid formulas in order to hydrate people back. And so I think that's a little bit too much, but it's certainly, if you have an imbalance and it's mostly water, then you have to replace water. If it's mostly electrolytes, then you have to replace electrolytes. And if it's a mixture of the two, you have to be careful on how you're going to replace them, because you could have swelling that third spaces in places that you don't want it to, like your brain, and that can lead to trouble, or your spinal cord. So heat stroke is an advancement of exhaustion. And that heat stroke really is where you have a dysregulation of your body's ability to maintain a correct temperature. And I remember when I was a resident, I had a patient that had this problem, but they didn't have it because they were exercising. They had it from a medication, and their core temperature got up to 106. And so it can happen when you have this sort of dysregulatory pattern. And boy, when it happens, you're going to start to cook a lot of you, and that's going to be a bad thing. So you usually have that core temperature above 40. So once again, it's kind of the gold standard. You do the rectal temperature, there you are. And so it's over 40. Now, in your head, you would think, okay, you got these symptoms. Your core temperature is a little bit, it's over 40. Okay, now I'm getting concerned. This is not exhaustion. This is actually more into stroke. And you're starting to have sort of CNS dysfunction. Can't concentrate. You're kind of awake. You're kind of closing your eyes. You're certainly not functioning well. And so that's when you would say, okay, this is not exhaustion. This is something beyond that. This is stroke. And so in your head, you're already thinking, okay, boy, I'm sure glad I didn't cover what Edwards was talking about before, because now I got a heat stroke, and I didn't have the EMTs there, and I couldn't rapidly cool the person because I had no ice, I had no bathing units, I had no IV access, and the person could really run into trouble. So rapidly cool, and then it becomes, if you're on the sidelines, that's about all you can do, and then you're activating all the other ancillary help for you. And then when they get to the emergency room, then it's really kind of a multidisciplinary approach because of all the different organ systems that get involved. And so if you do it rapidly, then you save lives. If you don't do it rapidly, then you don't save lives, and that's where 10%. So you imagine 1 out of 10 people don't survive, and that's what happened to Korey. And so that's why it's important, because, boy, I'd like to see that number 1%, not 10. And it's something that we can actually do something about, unlike a terminal cancer where there's not much else we can do now, I'm sorry. This one, boy, there's a lot to do, and if you do it quickly, you can actually prevent death. So how, and this is where I think this is awesome. These are the part of the talks, other than the pathophys and talking about the symptoms and signs and what to do. Well, how do you prevent some of these things? And so there's a lot of debate over this, but there's a lot of position stands too from the American College of Sports Medicine, the American Medical Society of Sports Medicine, the American Orthopedic Society of Sports Medicine, some of the internal medicine academies, family practice, pediatrics. They all kind of get involved, and also the ATCs. There is tons of research on this. So how is it that you can really measure a person's hydration status? And where I trained at UCLA, we often had to measure people's weight before they exercised and then after, particularly football players or two-a-days or warm season sports. And you would take a look at their hydration status by the amount of percent of body loss that they had. And if they were around 2 to 3% down, then you would say, oh, you were dehydrated. And you'd ask them, how was your performance today? And they'd say, yeah, it wasn't all that great. I felt like I was a little bit run down. My legs felt heavy. And so then you would educate them and say, well, maybe there's a way that we can prevent that. So you didn't get to heat exhaustion. I got a couple cramps. It would be, okay, listen, why don't we talk about, let's get you hydrated now, but how can we get you hydrated throughout the activity and then maybe even prior to the activity? So rehydration, after exercise, 16 to 24 ounces of fluid of electrolytes, and for about every 0.5 kilograms lost. I mean, that's a good starting point. And you might need a little bit more, you might need a little bit less, depending on your fitness level. But certainly, that's a good start. If you think, well, how can I get myself kind of going? And I think the best way to think is, well, if I hydrate myself ahead of the event, then I'll be kind of euvolemic. I'll be right where I need to be. So prior to that exercise, I won't be at a deficit. So making sure that, if you're a high salt sweater, you got a lot of salt stains on your shirt when you're doing your event, or either working out for your event through, your training, then you would say, well, maybe I should kind of tack on a little bit more of the salt on my food. I should maybe heavily salt it. Or throughout that activity, if it's going to be more than an hour long, maybe I need to get myself into sort of, rehydrating myself with appropriate fluid replacement. And so would it be just water, or would it be water with electrolytes in it? And I think we all agree that it's the water with the electrolytes in it that probably provide benefit. The problem with it is that it tastes terrible. And so you add sugar. And if you add too much sugar, it tastes great. If you add not enough, well, then it still tastes terrible. And the good thing about when you're exercising over an hour is that if you add that sugar, in a simple sense, which we'll talk about more, you will actually get some sort of benefit to kind of refuel the machine. If you put too much sugar in, you'll get the old dreaded Montezuma's revenge, and that could be detrimental to your performance. So, really I think those are kind of the key issues with that prevention. So now I'm going to switch gears and move on to carbohydrates. And how many people love carbs in this room? I think I love carbs. Chips are my nemesis. And so it's really, broken down into a couple different types of carbs, right? There are simple carbs and there are complex carbs. And simple carbs are like sucrose, table sugar, fructose, glucose, and some of those are called empty calories. Does everyone know what empty calories are? So empty calories are carbohydrates that don't have any other sort of micronutrients in them. They don't have any other sort of wonderful things that you get from some of the complex carbohydrates, things that are useful for a person in training. So the complex ones, pasta, another one of my nemesis, so good. Whole grain bread cereals, they're a little bit harder to digest. So if you're thinking, I'm going to run a marathon today, and halfway through, I got my little box here. I'm going to pull out my pasta with my meatballs, and I'm going to just throw that down the hatch as I'm running along, and I'm going to get re-energized, and things are going to be good. Probably not a great idea, right? You'd be thinking, well, maybe I should use a simple carbohydrate that's going to be easily digested. It's going to provide me with energy, and I'm going to be able to compete without having any of the gastric side effects or stomach cramps. So, that's the main issue. Well, then how much should we consume, really? And I think when I was growing up, probably just like Dr. Peifel and Dr. Elder, man, you need a carbo load. You better carbo load like for a week ahead of time, because you're going to expend a ton of it. And so really, that hasn't been proven to be effective. And I do have a couple of sheets on this that I think were passed around on the table. And you can kind of see on that sheet where it talks about what your activity status is and what you should do as far as carbohydrate either loading before your activity, which is usually a standard of about 4 hours before. There is some evidence that maybe 24 hours before may help you, but certainly 4 hours before is, the standard. That's been proven to be effective. And so really, if you think about your diet, now I'm probably closer to 80 to 90% of my diet is coming from carbs. I should probably back down on that. But 50 to 60% is really the ideal. And then you think, well, how much should I intake? And I converted some of these numbers so it's a little bit easier for you to kind of calculate by looking at that nutritional slip on the back of your packages. But 200 to 300 grams of carbs about 3 to 4 hours before your exercise is ideal. And there may be some benefit for that 24-hour load. But probably the most important thing to get from this part of the talk is that you need to replenish the source if you're doing activities greater than an hour for the most part. And so if you think of the replenishing at 0.7 grams of simple carbs per kilogram of weight for exercise lasting longer than an hour will help. And what does that equate to? Because I see those numbers and I say, okay, I need to do some calculations because that's not going to help me when I'm trying to figure that out as I'm running my marathon and dying. I need to figure out what I need to take in because they either come in sports drinks or these little gel packs, or there's G2, there's more sugar in that one. There's light sugar, and there's tons of different sports drinks. So which one should I do? And I think if you take any sort of standard sports drink, they're all pretty similar if you actually look at the quantity of carbs in them. If you took 1/2 to 1 of those drinks in a given hour of exercise, you'll probably be pretty close. If you need a little bit more because you're running at your machinery needs a little bit more and you don't get any gastric side effects, we'll bump it up to maybe 1.5. If you don't need that much, then maybe stay at 1/2. So that's a good thing. And you can kind of, then you could balance that out with the gel packs if you'd like. There has been new evidence, though, where we wanted to keep this kind of around 30 to 60 grams an hour. That's what I'm basing those kind of sport drink mixtures off of. That if you're doing anything over 2.5 hours, because we have these crazy people like ultra marathons. Anybody ultra marathoning in here? You run 2 consecutive marathons in a row because it's cool. And agonizing pain, suffering. You love suffering. But they think if you're doing something at a prolonged state, and they say here over 2.5 hours, then you might want to be at around 90 grams an hour. So you would just take a little bit more of the drink. Protein How many people take care of kids who go bananas on how much protein they take? Can I see a show of hands? So not that many. I don't know, 10 years ago, I swear everyone was on muscle milk or protein shakes, or they'd go to Jamba Juice. Oh, I want the protein powder. Throw that in there. Yep. I haven't worked out a day in my life, but that protein powder is going to do me some good. So people just went bananas on it. And so, do you take soy protein, animal protein, which one's better? Tons of different, look at that slide up there. Just a ton of different types of proteins, right? Powders, mix it with milk, don't mix it with milk, mix it with water, mix it with an energy drink, get the caffeine. There's a ton of different ways and preparations for this. Let's get to the nuts and bolts again. How much should we consume? And why is it important, right? So, protein, it's a great thing. It helps you build muscle. Right? So, if you think of your daily requirement of being around 15 to 30% of your caloric intake being protein, which is the standard, then you would think it's probably 1.2 to 1.7 grams times your ideal body weight in kilograms. So I gave an example because you just got to have one, because you throw out those numbers and I don't know. I see a lot of blank faces like, I don't know what that means, but that example, I understand that. So you throw it into an example, you say, okay, 90 kilos roughly for a 190-pound guy or gal, and it's about 40 to 70 grams of protein. Now, you could read that off of a package, right? You could look at the back of the package and say, well, how many grams I'm getting per serving, and then do your calculations that way. So that would be kind of what you would want. Well, if you think about the amount of protein that you would have, that these sport drinks have, it's a ton. And it really provides you about 25 to 50 extra grams of protein, which is a lot more protein than you would need, even if you were Arnold Schwarzenegger in his golden days. So it's just a lot of extra protein. Well, what happens to that extra protein? Well, it has to get excreted. So there'll be troubles in the future if you keep doing that. Well, how much could you get from just daily substances of things that we know? Well, like a skim milk, 8 ounces, you get about 8 grams of protein. And so like a 1 ounce piece of meat, it's roughly about the same thing. So if you take too much protein in, you're going to end up producing ammonia because it's going to be made from the nitrogen. And that's going to have detrimental effects on the liver. And if you take in too much protein, the big molecule has to be excreted by your kidneys, and you're going to over-filtrate that stuff and lead to damage in your kidneys. So you really got to watch out how much these kids are taking. And I would tell you, most of the kids that I talk to when they're taking these protein shakes, some are taking 150 grams. And one of the guys that's a dear friend of mine that I work with, he is in the medical field, and he was taking about 150 to 200. So, way more than you would need. So why is that important? Well, how much do you need to build muscle? Does anybody know? Well, I'll tell you, because I looked it up and I did the calculation. So if you think, how does it affect your performance? Well, that first line, it really doesn't do anything for your performance. So if you supersaturate yourself, what's the point? It's not going to have an effect on my performance, really. The only thing that I've ever seen, which some of my friends do, is they go bananas on the protein, and they go low carbs, and they're like, dude, look at all the weight I lost. Man, look good. So there's probably some benefit to that. Certainly we see it. But when it comes to performance, probably not much at all. So what if I wanted to gain 10 pounds of lean body mass? That's what the LBM stands for. And I'm not 150. It'd be nice if I were. But if I were 150 pounds, what would I need to do? Well, I need about 10 to 15 grams more per day than what I would take in normally, as we discussed. And so I would have to drink 1 to 2 extra cups of skim milk. Boy, that's a lot different than spending $45 on a big tub of whey protein and getting 80 grams of protein in when I didn't need it. So I think that's why I made it red, because, boy, when I did that calculation, I was like, wow, that was a lot less than I thought it would be. Does that make sense? So my favorite is the guy on the bottom. Look at me. Now look at me. And wow, that's pretty good muscle tone right there on the woman on the upper right. I'm scared. So creatine, let's switch gears. So what is creatine? Well, creatine is used by your body. It's a natural substance. It's what we use first, actually. And so it helps us produce energy. And that energy then is converted into us moving around. And so, well, how's it made? Well, it's made synthetic. You know, this stuff that we're talking about with those slides of all those tubs of creatine, it's synthetic. And so, well, if we think about exercise in general, there's two phases of exercise. There's an anaerobic phase, which is the first initial phase, and then there is the aerobic phase. And so creatine really is one of the first things that's utilized by the body when you just start your exercise. And that allows us to have direct energy. And so the thought was, boy, if I supply more creatine, I'll have more initial burst energy, and then I won't have to go through this whole cycle, the Krebs cycle and all that for the aerobic part of it. And so, all right, if I just supersaturate my whole body with creatine, exogenous creatine, then that's going to be great. Okay, so you take it in, you take a bunch, and you think, okay, look at that, I'm looking bigger. Man, I took this creatine, I'm looking bigger, things are good, I feel like I'm getting strength gains because I feel positive about it. No one really knows if it's going to help you or not, but it certainly will increase the water content of your muscle. So is that really muscle, or is that just swollen muscle? You know, so that's the issue, and I think no one knows. Well, does it work? Well, it's coming off the shelves like hotcakes, and that goes back to this DeShay Act, where, boy, is it really creatine that you're getting, or is it something else in the creatine that you're getting? And one of my colleagues at UCLA, Dr. Green, he actually did a study where he went into GNC and he said, I'm going to take randomly 12 things off the counter here, and I'm going to see what they actually have, because the lab that we were working in was called the Olympic Lab, and it was associated with UCLA, and they just got gobs of money because, well, they took care of all the NCAA, the Olympics, and all the drug testing. So there was a lot of, money that was supporting what we needed to do for those entities, and that allowed us to have big, cool machines to see what's actually inside these pills. And what was found is that a majority of these pills were not accurate with their labeling. In fact, they were quite off. And some of these pills had substances in them that we know work. So, gee, you got muscle aches? Try this muscle ache supplement. And what was in it was ibuprofen. Or, gee, you need to have, better circulation. And so what was in that pill was foxglove, and we know foxglove is where Coumadin comes from. And that's a blood thinner. And it would be in minuscule amounts, but it still was there. And it just, no one knew, no one cared, because it was not FDA regulated. And that still exists today. And so when I see patients that say, man, I'm supplement crazy, like my neighbor that I grew up with, his mom is supplement just nuts. I mean, you go into their medicine cabinet, it's got to be 45, 50 different supplements. And I see like her daily regimen, it has to be 15 to 20 tablets. And so that's probably too much. And no one knows what's in it. So I think that's the point of when you use supplements, and that's what I talk to the high school students, the college students, and the professional athletes. It gets a little bit less as you get a little bit towards the professional athlete, because there's drug screening, and drug screening will pick up some of these other substances, and of course then you're not going to get paid and you're going to be disqualified. So it's more, 6% or so, even as high as maybe 15% of the high school kids are doing these things. And that's maybe underreported. So I use that as kind of, well, here's fuel for the fire. Do you know exactly what you're taking? And they say, sure, it says on a label. And I say, well, it's not always accurate. So that's helpful, especially in our field where we see a lot of these people. Well, has it been proven to provide muscle growth? Don't know. How about power? Yeah, but not totally. So it varies. Some person may get a great benefit, some people don't. There was this whole idea maybe there's a responder and a non-responder, but it's still up for question. So how much should you take? Well, I don't know. More must be better because that's the golden rule. I don't know. No one knows. So 400 milligrams per kilogram of your weight, and you're not supposed to exceed 25 grams. I wonder how many people do. Probably a majority. So what are the risks associated with it? Well, some studies say you get compartment syndrome. Some studies say you get dehydration. And some say you get nothing at all. And so no one really knows, so it's pretty controversial. But there has been some reported literature of organ trouble related to it, and they don't know if it's really the molecule or the substances other inside this creatine that they were ingesting that they didn't know about. And there was some people that documented that, yes, this person was taking creatine, there was no other source for the compartment syndrome, and they got it. And it wasn't exertional compartment syndrome, it was compartment syndrome. So, very controversial. I got 2 slides that are my favorite, and my favorite is that big guy on the left, or your right. Yeah, I love this. And the saying, sometimes you just can't tell. God, that guy's huge. Right? And that other guy, I mean, come on. Steroids? I wonder. And so steroids come in, multitudes of categories, but, injected or oral, we'll just keep it kind of simple. Here's my other slide. And don't come back. It says, welcome to the state fair, and the police officer says, and don't come back. I've never been so humiliated, as the wife is saying to the husband, and the husband says, well, how did I know they would test for steroids? So what are steroids? Well, the ones that we're talking about is testosterone, and testosterone is an anabolic steroid, and they're catabolic steroids too, right? Things that are like, prednisone, but they're anabolic ones that actually help with building, and so that's what we're talking about, testosterone. And it's in your body, it's in women's bodies, and it's in men's bodies, and so we have it, it helps us, it's a hormone, we need it. And so, well, what does it help you do? It provides you with secondary characteristics, right, if you have a certain amount of it. So, well, there are a lot of them, but I break them up into 2 categories just because it's a lot easier. And so there's an oral and an injectable. And a lot of people don't like the orals because the orals actually have a first pass. And what that means is that you have to ingest them, they have to go into your stomach, and then they have to get filtered through systems like your liver. And so if there are problems in the pill, your liver is going to take a bigger hit. Injectable, you don't really have to go through the liver. It's already in your blood system, and it's going to go directly to the cell. So, well, the risk is a little bit higher, but maybe that's controversial with the injectable, but there are more. You got the injectable types of problems, so hepatitis, HIV, infection. And did anyone ever see the episode where the guy was just doing a lot of arm curling, and he was injecting himself with testosterone, and he would just do it without cleaning a needle. He would just use the same one repetitively, and he ended up having like the largest biceps on the planet for a little while, and it got infected. And then he started to try to treat himself by, drawing out the fluid of infection himself or trying to cut it open a little bit, and then got worse infected and ended up having a bunch of his muscle taken out. So he's no longer having the largest biceps in the country. So could it be a problem? Yeah. Was that just the testosterone causing the muscle to be a problem? Or was it, having an effect on his psyche? Probably a little bit of both, right? So does it work? Well, ask anyone who injected it. Yeah, it works. So no question. Totally works. That's why people take it. So how do you address that with a person? You say, well, we know it works. It makes you stronger. However, there's these risks. And, if you want to play fair, it's banned by sport, so it's drug tested, so you're going to get caught, number one, unless you have some sort of other way to do it. And there's a lot of different ways that people can do it. And it's interesting, which is something I thought was kind of, you tell me what you guys think, but the recommendations now is that you have to have a certain level of testosterone. And if you're over that level of testosterone, then you are considered to be positive. And if you're under that, then it's considered to be okay. And the normal level is, let's just throw out numbers. Let's just say the normal level is 1.2, and that can be about where it normally lies. And then if you go several standard deviations beyond that, let's say it's 1.6, and that would be the new standard level, where if you're above that, then that would be considered positive. Well, it's the same for women and men. So I want to know why doesn't that seem a little odd? But it is. It's the same level. So as a woman, you might benefit from, juicing up a little bit. And just kind of stay at 1.5, say. You might have a Billy D mustache and some facial hair and a nice 5 o'clock shadow, but hey, you'll be very competitive. So, it's interesting though, but that's how, it's interesting how that pans out. But there are other big risks, right? And the ones that I think we get really worried about are going to prison. So that's one. Some people probably not so much, but I'm pretty and I wouldn't do well in prison. And so the other ones are, irreversible problems. And those are cancer, right? Particularly in the liver, usually because of the first pass, orals, HIV, hepatitis, coronary artery disease, although they think some of that risk with coronary artery disease is reversible after you take it, but certainly during it, there's some risk there. Depression, and that kind of leads to, was it concussion that caused you to be depressed in some of these pro athletes, or was it something else? Could there be a contributing factor that is beyond concussion, like maybe were you utilizing an illegal substance like testosterone? So, it's certainly controversial. And then you got hair loss and acne, and if it's scarring acne, it's certainly not reversible, and hair loss usually is. So, well, what are the problems? Holy cow, could we get a busier slide? And so there's a lot, right? But a majority of them are reversible except for some of the ones we talked about. So people still utilize it, there's no question. So that's the end of my talk, guys. Yeah, I don't use it all. Awesome slide. So I did put a list of references there, and I wanted to make one more comment. The other sheet of paper that you guys have there, which I didn't get into, which is called the athletic triad. There is certainly some energy imbalances that we see in female athletes, more so than male athletes, but certainly as important in male athletes as female athletes. But it's a good calculation to talk about energy balance, and it really just goes through the algorithm there and allows you to get a kind of a baseline for an athlete that you may think will be at risk, where you kind of look at them and say, well, you're a little risky, and you can talk to them about their energy balance so that you can tell them how many calories they need to take in, and if they're working out, to what level they need to be taken in. So thanks again for your time. Appreciate it.